Welcome to the Deep Dive. Today we're tackling a really interesting development in medicine. How the internet and things like telehealth are, well, increasingly becoming part of vascular surgery.
Exactly. And for this deep dive, we've got material from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. It's pretty much the standard text.
Right.
Our mission, really, is to understand how these technologies are changing things. How surgeons diagnose, treat, and maybe most importantly for you, how patients are monitored after procedures.
Okay, let's unpack this. It sounds very modern, but this idea of remote care,
Yeah.
it's actually been around longer than you might think, hasn't it?
That's true, yeah. The telephone, way back in the first half of the 20th century, that was kind of the first step, sharing health info remotely.
Just a phone call.
Well, yeah, but then things got more advanced. There are actually reports of radiological images, like X-rays, being sent over phone lines in the 1940s.
Wow. Over phone lines. Must have been slow.
Oh, I imagine so. But that early stuff paved the way. Then NASA, they really took it further. They developed remote monitoring for astronauts. Think about that, keeping track of someone's health from, space.
Right, that's complex. Monitoring vital signs from millions of miles away.
Exactly. That really pushed the technology forward.
Space-age tech filtering down. So when the internet properly arrived in the 90s, that must have been a huge leap for this.
Oh, absolutely transformative. Suddenly, you could exchange medical images, information almost instantly. By 93, surgeons were doing consultations across continents.
Across continents in 93.
Yeah, and that same year, the American Telemedicine Association was founded. They were crucial in pushing for wider adoption.
Okay, so the groundwork was laid, and now, well, nearly everyone has a smartphone. How did that change things?
That's a critical piece. Mobile tech, smartphones with cameras. It made telemedicine so much more accessible. Pew Research data from 2019 showed like 90% of Americans using the internet, 81% owning a smartphone.
Huge numbers. Everyone's connected.
Pretty much. And internet speeds got better, faster, more reliable, so real-time video calls became practical.
Right.
But it's not just video calls. There's also remote patient monitoring, or RPM. That's using digital tools, special stethoscopes, eye exam tools, ear exam tools, wearable sensors to track health data remotely.
RPM, so gadgets that watch your health metrics at home.
Basically, yeah. Like the FDA cleared a digital stethoscope from a company called Telemedicine. It even has some AI support for diagnosis.
AI built in.
Yeah, and think about smartphone apps. Now they can detect arrhythmias, heart rate, blood pressure. Those could be really useful signs after surgery.
It's amazing how quickly this stuff has developed. With telemedicine already making inroads in surgery, like vascular surgery, before COVID hit?
Yes, it was definitely gaining traction. U.S. hospitals using telemedicine jumped quite a bit between 2010 and 2017, from 35% up to 76%.
Wow, that's a big jump.
It is. And insurance claims for telehealth were going up, too.
So COVID wasn't the start. It just poured gasoline on the fire.
Exactly, an accelerant. Plus, there's this projected shortage of surgeons.
Oh, right.
The AAMC expects a pretty big shortfall. So telemedicine is seen as one strategy, maybe, to help specialists reach more patients, be more efficient.
Makes sense. Stretch the expertise further. And what about the quality of care? Does it measure up?
Well, research suggests that for some things, yeah, it's just as good, sometimes maybe even better than in-person visits.
Really better.
For certain conditions, perhaps, like varicose veins. Studies found patients were pretty happy with virtual clinics, especially when they use things like point-of-care ultrasound. You might have, say, a nurse at a local clinic helping with vitals while the specialist connects remotely.
Interesting model. Okay, so things were moving along, and then bam, COVID-19, that must have changed everything overnight.
It absolutely did, a massive catalyst. In the U.S., the Stafford Act in March 2020 let Medicare and Medicaid, CMS, basically blow the doors open for telehealth access and reimbursement.
Right, they loosened the purse strings and the rule.
Pretty much. And lots of private insurers followed. States waived some licensing rules so doctors could see patients across state lines more easily.
A rapid shift in regulations.
Definitely. The AMA, the American Medical Association, stepped up too, creating guides for doctors on how to use these virtual tools effectively.
And this wasn't just a U.S. thing.
No, not at all. Australia had already invested in telehealth before COVID, and they expanded it. The UK's NHS ramped up video consultations too.
And the uses expanded beyond just doctor visits, didn't they?
That's right. We saw it pop up in mobile integrated healthcare paramedics using virtual consults, community paramedicine, loads of new health apps. AI and diagnostics got a boost, even robotics in isolation wards.
So looking back at that huge sudden shift, what were the main upsides?
Well, the pandemic really highlighted the key benefits. Obvious one, reducing exposure risk for everyone.
Crucial then.
Absolutely. But also better access for people far away or who couldn't travel easily, getting expert guidance to maybe less experienced clinicians remotely, making better use of limited resources when hospitals were swamped,
Right.
and it helped with disease containment, contact tracing, even epidemiological research.
Okay. Let's pivot now specifically to vascular surgery after the operation. What are the big advantages telehealth offers patients recovering from those kinds of procedures?
Yeah, good question. It's created this unprecedented level of accessibility.
Yeah.
And for post-op vascular patients, the big wins are really around saving time, reducing travel hassles, and cutting costs.
Time, travel, cost.
Yeah.
Everyone understands those. Travel after surgery can be really tough.
It really can. There was a study in Michigan, patients averaged over 30 miles, nearly 40 minutes, just one way for an appointment.
Wow. Each way.
Each way. And think about the total time travel, parking, waiting room. The average American spends over 2 hours for a doctor's visit, but only gets about 20 minutes face-to-face with a doctor.
It's a lot of overhead for 20 minutes of care.
Yeah. Exactly. Telemedicine can basically wipe out the travel and waiting time. That means much more of the interaction is actual doctor-patient time. One general surgery study found it cut the patient's total time commitment by 85% when you took out travel.
85%. That's huge for convenience and vital for people in rural areas or who have trouble getting around.
Absolutely. Huge boost in access for rural patients, military folks, people in prisons, those with mobility problems, the elderly, anyone without easy transport.
And the cost savings.
Ah,
It's not just the appointment fee, is it?
no, definitely not. Think about gas, parking, bus fare, maybe taking unpaid time off work, arranging childcare.
Right, or a family member taking time off, too.
Exactly. All those hidden costs. Telehealth can slash those.
So real economic benefits, too. What about the actual clinical side? Post-op triage, follow-up. How does telehealth fit?
It's been looked at a lot across different surgeries, including vascular. Generally, the findings show clinical outcomes are pretty comparable to traditional care.
Okay, comparable is good.
Yeah, and some studies even hint at potentially fewer ER visits or readmissions. Maybe because patients can get concerns addressed sooner, more easily.
That makes sense. Catching problems early.
Exactly. And specifically in vascular, one study on surgical site infections after arterial procedures found no real difference in short-term readmissions between telehealth and standard follow-up. But interestingly, the telehealth patients reported being more satisfied overall.
Higher satisfaction.
Yeah, and we see it too when patients can easily use smartphone apps for virtual visits. They tend to stick to their follow-up schedule better, fewer missed appointments.
Okay, lots of potential upsides. But there have
Tons.
to be challenges, right?
Yeah.
Especially in surgery, which is so hands-on.
Oh, absolutely. You're right. Adoption is growing, but it was initially kind of slow in vascular surgery, and there are still some major barriers. COVID pushed it, sure, but it's probably not going to replace all in-person visits. It's proving useful for triage, for certain post-op management, but limitations exist.
Let's dig into those barriers.
Yeah.
You mentioned distance before in terms of travel, but it means something else here too.
Right. Here, distance is more about the digital divide. Not everyone has reliable, fast internet or the right device. A smartphone, a computer with a camera.
Ah, the access issue.
Exactly. Broadband access is often lower in rural areas compared to cities or suburbs.
Yeah.
That can just flat out prevent some people from using telehealth effectively.
Right.
And even if they have a device in a rural area, the connection might be slower, less stable. You get poor video, bad audio that really compromises a virtual assessment.
Yeah, a choppy video call isn't ideal for medical care.
Yeah.
What about the people side? You mentioned technology anxiety.
That's a real factor, especially for older adults, and they make up a big chunk of vascular patients. Some just aren't comfortable with virtual visits. They might feel it's less personal or maybe don't trust it as much.
Or just struggle with the tech itself.
Yeah, exactly. Lack the technical skills or confidence. We often see family members having to help out. And sometimes, a planned video call just turns into a phone call because of tech problems or the patient just can't manage it.
So access and user comfort are hurdles.
Yeah.
But medically speaking,
Yeah.
the elephant in the room must be the physical exam, right? How do you do that remotely?
That is absolutely the core challenge from a surgical perspective. Taking vital signs, for instance, we do that routinely in the clinic, remotely. Only works if the patient happens to have their own blood pressure cuff, pulse oximeter, etc.
Right. You can't just reach through the screen.
Exactly. And while video or photos give you some visual clues, the quality depends on lighting, the camera, image compression. It's not the same. And what a patient tells you about their symptoms isn't always what you'd find on a physical exam.
It's just not the same as actually palpating, feeling for a pulse, checking for tenderness.
Not at all. Telehealth limits you mostly to inspection, looking and listening to the patient's description. The classic exam elements: inspection, palpation, percussion, auscultation. You lose most of that.
So key signs could be missed?
Potentially, yes. Things like tenderness, swelling that feels boggy or fluid-filled, what we call fluctuance, hearing a brute, an abnormal sound in a vessel, or doing specific provocative tests, like an Allen's test for hand circulation. Those are really hard, often impossible to do virtually. And that does raise the risk of missing something or delaying a diagnosis.
That's a major concern. Are there technologies emerging to try and bridge that gap? You mentioned RPM earlier.
Yes. There is work being done. Some promising developments in remote assessment tools, for example, infrared sensors to measure foot temperature. Changes in temperature could potentially indicate how well a bypass graft in the leg is working compared to a baseline.
Indirect measures.
Exactly. Patients obviously can't do their own ultrasounds at home, but researchers are looking at these kinds of indirect ways to track blood flow and tissue health. It's an active area.
Interesting. Okay, what about screening and surveillance? Follow-up after vascular surgery is critical, right?
Hugely important. Long-term success often depends on regular checks. But the official guidelines, like from the Society of Vascular Surgery, they often don't have super strong evidence saying exactly how often or how surveillance should be done.
Really?
Yeah, we know imaging ultrasound, CT scans is key for checking if repairs are holding up, finding problems early.
But do patients actually get that follow-up imaging consistently?
Well, that's the surprising thing. Studies show compliance, adherence to recommended imaging follow-up. It's often not great, even before telehealth became widespread.
Why is that?
Probably several reasons. Geography, travel barriers again, cost of the scans. Maybe patients don't fully grasp how important the follow-up is.
Okay.
But the worry is if we don't have close to everyone getting the recommended imaging, we don't really know the true long-term outcomes or how much surveillance is truly needed.
So just relying on patients reporting symptoms during virtual visits might miss things that aren't causing obvious symptoms yet.
Precisely. There are some online apps where patients can log symptoms or events, potentially alerting the team, but that depends entirely on the patient being motivated and accurate.
Right.
Telemonitoring kits have worked okay in some other fields for short-term follow-up, maybe a few months, but vascular disease often needs watching for years, sometimes lifelong. Most remote apps right now focus more on preventing immediate post-op problems, death, readmissions.
And readmissions are a big deal, a measure of surgical success.
They really are. A study back in 2014 showed pretty significant 30-day readmission rates for common procedures, leg bypass, EVAR, open AAA repair, carotid surgery. Difficulty monitoring patients remotely definitely plays into that. And then you have all the background stuff, the data infrastructure needed, security, privacy, legal issues around all this remote data.
It sounds like we're still figuring out how best to use remote monitoring for long-term vascular care.
We are, absolutely. But there's exciting stuff on the horizon. People are researching smart grafts or stents.
Smart grafts.
Yeah, imagine implants that could somehow sense a problem, like they're about to fail, and alert the surgeon without needing repeated scans.
Wow.
The dream is this sort of perfect triad: real-time flow measurement from the graft, continuous vital sign monitoring, and easy interactive video visits.
That sounds like the future.
It could be, but again, we circle back to the barriers. Patient tech savviness and, crucially, reliable internet access everywhere, those hurdles remain.
Okay, so looking ahead then, what's the overall picture? Where is telehealth heading in vascular surgery?
Well, the push towards value-based care, where outcomes and cost-effectiveness matter more, plus this growing comfort level with telehealth from both sides, patients and doctors, it's definitely opened doors for innovation.
So the momentum is there.
I think so. People who got used to virtual visits during the pandemic, many will likely want to keep using them for certain things. And the market for telehealth apps, devices, it's booming.
So it's not just about replacing clinic visits, but maybe adding layers, making care more flexible.
Exactly. The hope is it expands beyond just follow-up visits, maybe even integrating remote tools for planning interventions down the line. We've seen in our own practice, actually, that just having nurse practitioners do close phone follow-up after discharge helped cut readmissions.
Just phone calls made a difference.
Yeah. So you can imagine that adding more sophisticated digital remote monitoring could improve outcomes even further.
But
But healthcare systems vary wildly, and implementing this stuff widely takes significant capital investment in the technology and infrastructure. That's a real-world constraint.
right. So wrapping up this deep dive then,
Mm.
it seems telehealth is definitely making big waves in vascular surgery. Lots of compelling benefits, access, convenience, maybe better outcomes. But also some really significant challenges remain, especially around equal access to the tech and that crucial limitation of the remote physical exam.
That sums it up nicely, yeah.
Yeah.
It's a tool with huge potential, but we're still learning how best to wield it.
Which brings us to our final thought for you, the listener. As this technology keeps racing ahead, how might totally remote monitoring, maybe even remote interventions one day, how might that fundamentally change the relationship you have with your doctors, especially in fields like vascular surgery? And what are the big ethical questions we need to think about now before we get too far down that road? Thanks for joining us for this exploration on the Deep Dive.